Hello and welcome to Health Professional Radio. I'm your host, Neal Howard, in studio with Dr. Bilal Iqbal from the Victoria Heart Institute Foundation in Canada. He's joining us on the program today to talk about a study concerning acute myocardial infarction and cardiogenic shock. Welcome to the program, Dr. Iqbal.
Thank you very much. Thank you for the kind introduction. Yes, I'm currently an interventional cardiologist practicing here in British Columbia, Canada. Previously having worked in the UK and having moved recently here to Canada and actively involved in research. As you highlighted, the study that we've conducted here in British Columbia is looking at the prognostic impact of revascularization strategy in patients with myocardial infarction and a cardiogenic shock. This is a very interesting topic and a one of significant debate over the recent years. And just to put everything into perspective, when patients come in with an acute myocardial infarction and cardiogenic shock, they undergo coronary angiography to determine the disease they have and the cause of the myocardial infarction. And, patients go on to have the culprit artery treated. But no one knows what to do with a non-culprit disease. Do you get on and treat everything in one go? Do you leave it and bring them back in another day? The arguments for it have been, this is a very sick cohort. Yes, you've treated the artery. If you fix everything else, you reduce the ischemic burden, and that may be associated with better outcomes. The argument against it is, well, actually, you've treated the problem of the heart attack. Let's let them recover. Why add to more complications for additional percutaneous coronary intervention that isn't warranted? And so, there's always been debate which strategy is better. And until, no one had randomized controlled trial data in this field. And over the recent years, there's been lots of interest in complete revascularization, culprit vessel versus non-culprit vessel intervention in stable patients with ST elevation myocardial infarction. So there's never been really any studies looking at a cardiogenic shock cohort per se. And if you look at our current guidelines, all of these had been derived from observational studies, and actually they weren't even actually derived from observational studies. They were actually derived from consensus. And so the recent culprit shock trials is a large randomized control trial. Actually, it's an amazing feat, to conduct such a large study in 706 cardiogenic shock patients, really sick patients. It was a tremendous achievement, and it showed that actually contrary to what guidelines previously suggested, you should just treat a culprit vessel intervention at the time of the acute myocardial infarction, and that's associated with better outcomes. And taking that, taking the results of the culprit shock into mind, we hypothesize that we may see the same effect in a real-world analysis. And that was the basis for our study, which we conducted in British Columbia. So our study involved 649 patients with cardiogenic shock, myocardial infarction, and multi-vessel disease. And our results actually showed were very complementary of that of culprit shock. We found that actually treating the culprit artery only at the time of the index coronary intervention procedure was associated with better outcomes. And we saw a clear signal, a very strong early signal, that multi-vessel intervention at the time of index percutaneous coronary intervention was associated with worse outcomes, increased mortality. So that's just a quick summary of our study, its key findings, and in relating to the background which actually stimulated our study.
Do you see any further need for research in this area?
I do, and because what we have done is an observational analysis. So it's not a randomized controlled trial data, but so I won't expect our study to be impacting, actually making guidelines. It's hypothesis generating data, but it's certainly complementary to the culprit shock trial, which is the first trial in this field. And, there still remains some uncertainties. Like, for example, if you look at the recent registry analysis from the Korean study, the Khmer data set, it has actually shown an opposite effect, right? But then it's very difficult to compare that study with ours and culprit shock because the definitions of culprit vessel and multi-vessel were very different. For example, in our study and in the culprit shock study, we considered culprit vessel intervention as just treatment of the culprit vessel at the time of the index intervention. And multi-vessel intervention was something that was conducted, all in one go. Whereas in the Khmer study, even staged interventions that were not part of the index intervention procedure were still were still classed as multi-vessel intervention. So when you have definitions varying between studies, it makes comparison studies very difficult. So as I say, I think the culprit shock trial, it's a large body of evidence, and already I can see it having some impact on guidelines. But I'm sure that certainly we need more studies to actually, and then obviously hope with powerful meta-analyses to delve into this further before I really see a significant impact on guidelines.
Well, is there anything that you see as any other implications for the interventional cardiology profession as a whole? I know you said you don't see any far-reaching implications as of yet. I guess to do so would be kind of jumping the gun at this point, yeah?
For sure. I mean, the thing is, I think with a cardiogenic shock cohort, and having already one large randomized controlled trial, 706 patients, yes, we do need more data, but it's very difficult to conduct such a study, and I'm not sure of any studies at the moment that are being conducted or planned to address this. And we may not see another study. We may not see another randomized controlled trial because it's such a difficult thing to achieve in such a sick cardiogenic shock cohort. But, it may well be that, with further more observational analyses that come through similar to ours, that may just be enough to start impacting guidelines, and time will tell, and we'll see. We'll see what happens. I can say this, that ever since the culprit shock trial has come out, we are seeing certainly here a change in the interventional practice in British Columbia, and I can also speak for some of my colleagues who are based across in England. Having spoken to them already, we are seeing a change in the thinking of a revascularization strategy in the cath lab at the time of myocardial infarction, cardiogenic shock, where people are now just primarily undertaking culprit vessel intervention, allowing them to recover and bringing them back perhaps as an inpatient, or allowing them to recover and bringing them back as an outpatient to treat the remaining vessels. So, I can already see a change in practice. I can see it. How soon it would impact on guidelines remains to be determined.
Well, I appreciate you coming in and giving us this information today, Dr. Iqbal. I'm hoping you'll come back in the future.
Thank you very much. Thank you for the opportunity. Thanks. Bye-bye.
You've been listening to Health Professional Radio. I'm your host, Neal Howard. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm.